Good morning. I'm Allison Brashear, the Dean of the UC Davis School of Medicine, and it is my pleasure to welcome everyone. I want to thank and recognize Vice Chancellor Prasad Mahabja, Ana Lucia Cordova, and the Office of Research team for their partnership in launching this distinguished speaker series and fostering collaboration across all of UC Davis. Throughout the pandemic, we have featured internationally renowned leaders and research advancements that are transforming our society and saving lives. The School of Medicine, along with its partners across UC Davis, continues to be a research powerhouse, including high-profile research on COVID vaccines like the Pfizer vaccine, boosters clinical trial, and innovations in testing and treatment. One of the nation's top medical schools for research and diversity, UC Davis School of Medicine will continue to be a leader in developing care innovations that improve health locally and globally. Now, it is my distinct pleasure to introduce our renowned speaker, Dr. David Kessler. In January of 2021, President Biden named Dr. Kessler Chief Science Officer at the U.S. Department of Health and Human Services. In his role, Dr. Kessler is in charge of efforts to accelerate the development, manufacture, and distribution of coronavirus vaccines. Dr. Kessler has served in several federal leadership roles, including his appointment as the FDA Commissioner by President George H.W. Bush, where he led programs related to the Nutrition Labeling and Education Act to protect consumers from misleading food labeling and launch of nutrition facts, food labels to help consumers, among other notable programs. Dr. Kessler holds a medical degree from Harvard Medical School and a law degree from the University of Chicago. Thank you for joining us today, Dr. Kessler. Today's program is a question and answer format, and I'm pleased to introduce our session moderator, Dr. Ralph Green, Distinguished Professor in the Department of Pathology and Medicine at the UC Davis School of Medicine.
Thank you, Dr. Brashear. It is indeed a pleasure and a great honor that you have joined us, Dr. Kessler. I thank all the attendees for registering for this as well, and in particular, those attendees from overseas. Many of our colleagues from across UC Davis and our fellow UCs have submitted dozens of advanced questions in anticipation of this exclusive opportunity with Dr. Kessler. I want to recognize and thank my colleague, Dr. Angela Haksu, School of Medicine Associate Dean for Translational Research and Director of Lung Biology, for amassing and categorizing these questions into common themes and monitoring the live questions that come through the chat. Time allowing, we will also try to include some questions from the audience, which will be inserted in the Q&A box. So without further ado, we'll begin with the first question. Dr. Kessler, when do you anticipate that a COVID vaccine could be available for children younger than 5 years? And what are the considerations for the rare severe vaccine reactions, including, of course, myocarditis? This has been very topical recently, this question. And of course, this is such a constantly changing situation with COVID-19 that as recently as this morning, there was an announcement which you might care to comment on as well, Dr. Kessler, and that relates to a new therapeutic agent that was announced by Pfizer. Over to you, Dr. Kessler.
A real pleasure to be with you, Dr. Green. You may want to tell the audience how we actually ended up here today. I had a clinical question on vitamin B12 in a patient question. And as I think I said to you, when you have a question on vitamin B12, a clinical question, where else do you go but to Ralph Green? And you were very kind, sir. But in return, you said, hey, by the way, would you mind spending a little time at today's event. So I am very honored to be here. A great deal of fondness for UC Davis and all the schools, and especially to your contribution in medicine, sir. So very appreciative of being here. So let's start. I can tell you how I started my day at 7 a.m. With Dr. Fauci, Dr. Walensky, about 20 of us, with the senior leadership at Pfizer. We had, from the very beginning of really coming the administration, we were focused on antiviral drug development. I obviously had the great privilege back in the 1990s when I was at FDA, working with Dr. Fauci on antivirals for HIV. And while great progress has been made on vaccines, we had not seen that progress on antivirals to date when we arrived. So we really a great deal of investment, some $3.2 billion on the research side, but also there were several molecules, one by Merck, one by Pfizer, one by Roche Atea, that were in the pipeline. So we started working very closely with our colleagues at NIH. And in fact, the NIH wrote the protocol for today's announcement that was carried out by Pfizer. As you know, Merck announced several weeks ago, Pfizer today. These are the first oral antiviral agents. With regard to the Pfizer one announced this morning, if you look at the eligible population, it was high-risk individuals at risk for hospitalization or death due to COVID. And there were several different cohorts. One included administration within 3 days. One included administration within 5 days, and really stunning results. I mean, I rarely use those words, but if you look at the cohorts, very highly statistically significant differences between the placebo and the treatment arms. The primary endpoint, I think, was 89%. It dropped down, I think, at the 5-day interval to 85%, but again, highly statistically significant. I don't want to get out in front of the FDA. An EUA has to be submitted, has to be evaluated. This is a protease inhibitors. We have experience with the protease inhibitors. The safety profile looks pretty clean from what I saw this morning. Some GI distress, a few cases of hypertension in the treatment arm. I'm not sure that has to be looked at, but again, very rare, but very clean. And I will tell you, if this bears out, I choose my words carefully, I think this can be a game changer. I think that, just none of this, and the most important thing to emphasize, okay, I mean, just 1, 2, 3, 4, 5, please, this is not a substitute for being vaccinated. It is absolutely critical for everybody to avail themselves of vaccines. They are highly, highly effective. I mean, I have seen people take the position that the monoclonals, which are, well, I'll just get a monoclonal, I'll just get an antiviral. You want to stop this virus before it attaches to any cells. Vaccines are, first, second, and third. But I will tell you, if this bears out and the data hold up, and I have every reason to believe that's the case, I can see light at the end of the tunnel, and I had not been able to say that before now.
Well, that's very excellent.
To your other question,
yes,
another great week. I mean, I will tell you, I had been waiting, just as I had been waiting for the antiviral data. I had been waiting for the data on kids 5 to 11. And I know you asked me about the age group below 5, but just, the fact was there was unanimous vote at the VRBPAC, that's FDA's advisory committee. There was a unanimous vote at ACIP. Children do transmit this virus. There's been some 1.9 million cases, some over 8,000 hospitalization. There's just been the amount of multi-system disease, the 8,000 cases of multi-system disease. A third of the cases of hospitalization end up in the ICU. This is also a disease of children. You saw the serology, for those of you who follow the data that was presented, some high 30s to 40% of children have positive serology. I was struck by that. But the number that struck me the most in the presentations to the advisory committee last week was the number needed to treat. And for every 9 children vaccinated in that age group, you could reduce you can prevent one kid from becoming infected. I mean, that's a profound ability to intervene. So I'm very excited. With regard to below the age 5, there's 2 cohorts that are being studied right now. There's a cohort that includes 2 to 5 and then 6 months to 2 years. I expect the 2 to 5, that study is underway. It's a dose de-escalation study, obviously, as all pediatric studies have been approached. I think we have to fairly say that it's likely first quarter. Might it be a little earlier at the end of this year? I'm not sure, but I think it's fair to say first quarter next year from that 2 to 5, and hopefully that next age cohort can follow soon thereafter. The issue on adverse events, on myocarditis specifically that you asked me about, I think that we tend to see the peak, and this has been studied really, very, very, very closely in that 16 to 24 year age group. Why that's the case, there's some hypotheses of why that incidence is higher. It's very important to recognize, if you want to see an exquisite presentation, please look at Dr. Sarah Oliver's presentation to the ACIP. It was an exquisite presentation on risks and benefits. And the reality is, luckily, the cases of myocarditis that are seen, and again, our experiences in the older age group, that's what we have the data on, is those are mild, and certainly the benefits of vaccine clearly outweigh the risks. The actual clinical studies, the clinical trials, about 3,000 who in that age group, was absolutely clean. There was no incidence of myocarditis, but again, you would not expect to see it if it has an incidence of 1 in 5,000, 1 in 10,000, if there are only 3,000. So all very good news. Good news on the antivirals, great news on kids. It's very important if we're going to affect transmission. And also, very honestly, children 5 to 11 deserve to be protected.
Well, that's certainly a great way to start and an optimistic outlook on what lies ahead. The next question is, what have our institutions learned regarding how to strengthen messaging to enhance public trust, especially regarding transparency in vaccine safety?
We have always taken a position that transparency is absolutely critical for public trust. I mean, I think it's almost fair to say we've obsessed about that transparency. And I think you saw that in this, I think, what was there, 7 cases of thrombotic syndrome with thrombocytopenia with J&J. We halted the use, even though the incidence was rare, to have a full public airing. We've been very careful to make sure as soon as we see a signal, that signal is out. So we've been great pains to make sure that the safety profiles of, first of all, look, the teams both at CDC and FDA, I've never seen anything like it. The dedication, the seriousness with that they take these adverse events really is something we can all feel comfortable in. Look, there's a lot of disinformation out there. There's a lot of, I mean, I'm under no illusion, right? I mean, just because I'm, chief science officer of the COVID response, there are people out there who are not going to listen to me just because I'm a federal, I'm a federal government official, despite the fact that I'm a pediatrician, despite the fact, I'm on leave, from the UC system, I'm, a doc. I think in the end, just take kids, for example, this 5 to 11-year-old cohort. If you look at the Kaiser Family Foundation, about a third of the parents said they're ready to get their kids vaccinated. A third say they're not going to get their kids vaccinated. I think what we experience is once they start seeing other kids and they hear from parents that it was safely done and how they feel about it, that momentum picks up. I wish, and I leave it to you, Dr. Green, and your colleagues. I wish we were better at dealing with the disinformation, the challenges to science. There's something afoot that is most troubling, but we work very hard at it.
Thank you, and that's clear in the manner in which you have portrayed this and the messaging that comes from the federal government. So the next question actually is a three-part question, and all of those parts are related, but I'll start out with, what have we learned from research regarding the transmissibility of the Delta strain in naturally infected versus vaccinated populations?
There is an excellent science brief that was issued last week by the CDC. It analyzes the 96 studies that are out there. And the studies are, as you would expect, are all over the place. There is no doubt that natural infection, the people with it have levels of immunity. We don't know, okay, how long that immunity lasts, or how much additional protection they can get from also getting a vaccine. But we do know that if you look at CDC research, that people with natural infection who remain unvaccinated are 5 times more likely to be reinfected than people who got the mRNA vaccine. So there is no doubt. Dr. Walensky testified yesterday in front of the Senate Health Committee. If the one thing that we can say with assurance is that if you've had COVID and have natural immunity, that immunity is strengthened by vaccination, and we encourage that vaccination. We don't have a perfect correlate, right? We certainly have neutralizing antibodies are certainly a correlate, certainly in this data that we've seen, and keeping those neutralizing antibody levels high, especially in the face of Delta, are very important. So, we're going to have to learn more about natural infection. We just don't know how durable it is.
And then going on along that theme, does herd immunity still apply, given that we know the transmission still occurs in the vaccinated? If so, what is the target for herd immunity to be effective? How important is vaccination of children in this equation, and at what level?
But those are the questions that I actually, those are the questions in middle of the night that I am thinking about and talking to my colleagues. Those questions are exactly on point. I think the bottom line is the thing that we do know is the higher neutralizing antibodies, they do correlate with reduced the number of cases, not just hospitalization and death. So I can't tell you exactly. My sense is you have there clearly is an effect of those neutralizing antibodies, and they do impact transmission. Exactly how much, I don't know. And I think that's the question. And especially in the face of Delta. Look, the more cases out there, the more your risk, my risk, even if we're vaccinated, even if we're boosted, of being hospitalized and or death. So we do have an obligation to get cases down. I will tell you, I disagreed with, fully respectful, right? But if you look at the primary endpoint for those vaccines, it was prevention against symptomatic disease. It was against moderate to severe cases. If you look at the VRBPAC, the advisory committee for FDA, in the discussions on boosts, they said, well, hold it. It works against hospitalizations. It works against deaths. We don't see the waning. We're starting to see some waning. The real waning is against cases and symptomatic cases. And vaccines weren't designed to do that. I disagree with that. I think certainly from both a public health point of view and from an individual people wanting to choose, I would like to protect myself against symptomatic disease. So, I mean, that's why I think I disagreed with some of that discussion, but I think those are the key questions.
Right. So another facet of that is, could measurement of the immune response, for example, neutralizing antibodies, provide an indication of a person's need for booster shots? And here in particular, the second booster or third dose, is there a way to monitor the need for that by looking at neutralizing antibodies?
Sure. I mean, if you had, and our colleagues, and we've spent an enormous amount of time trying to standardize, and this, Dr. Green, well, but getting the standardized, the kind of diagnostic tests that these are talking about, I mean, in the hands of some of the great laboratories, the pseudo-neutralization, antibody titers, that would be great if those were commercially available and we had reliable measures. From a public health point of view, I'm not sure that is really, the most efficient way to do it. Look, if you just look at the latest data out of Israel below the age of 65 on the Pfizer, I'm sorry, this is the clinical trial data, I'm sorry, that Pfizer has in its phase 3. If you just compare the number of the efficacy of 2 doses versus 3 doses, right? There's a vaccine efficacy. I mean, it's high. The boosts really do provide, I mean, certainly on symptomatic infection, a profound advantage. 3 doses over 2. I didn't expect it to be that high. So in light of that, the waning that we're seeing and the profound increase in efficacy of 3 doses over 2 in that controlled trial, I think that sure. I mean, academically, in individual cases of immunocompromised individuals, I can make a lot of cases. I would love to have a standardized commercially available test that people could use, but I think the case for boosts is very strong.
And then just to follow up on the points that you've made, is it too early to say whether the degree of immunity conferred by that third dose is more long lasting, given the fact that one might expect that by what we know of half-lives of antibodies, it may start off high, but will it decline in the same manner or will it persist?
That's the question that is before us, that we don't have the data that we have to get. I think if you talk privately to my colleagues, I think almost all of us agree that if we were doing this from the beginning, certainly with the mRNA vaccines, this would have been a 3-dose regimen, and to include the 1, 2, and 6 months. I think we really feel we're calling it a booster, but you can view it as a primary season. And how long that lasts, I have no idea. I think we do. I mean, if I were a betting person, not based on any data, right? But I don't know this, and I'm not ready to. I don't know what the data will show. I would not be surprised if those who are most vulnerable, let's say those elderly, I mean, those who are immunocompromised, we need to continue to boost. But let's see. I mean, I'm not ready to draw any conclusions of whether this needs to be annual. Now, the most important thing is the way we work here is, we have to be ahead of where, if in the hockey metaphor, where that puck is going to be, right? So we are always thinking. I mean, when people were doing 2 doses, I was worried about boosters. When we were doing adults, I was worried about kids, because I can't turn on 400 million doses or 200 million doses, I mean, overnight. So that takes time to plan for. So we're planning for all these contingencies, right? But I mean, right now, the boost data really is exquisite. People should get boosted. I would hope that there's more durable out of the 3-dose regimen, but we'll have to see.
So we're hopeful that you will succeed in the Wayne Gretzky approach of seeing where the puck's going to go and stay ahead of the game. The next question is regarding vaccine availability. Can you share the progress being made to increase access to COVID-19 vaccines in lower and middle income countries, and plans for the US donating a fabulous 1 billion vaccine doses to low-income countries? As a follow-up, in the US, does the use of booster shots for adults or children 5 to 11 in certain very low-risk groups reduce our ability to provide the vaccine to people at much higher risk in other countries? Or is the supply not an issue?
So let me tell you what we've done. I mean, today, because I've been integrally involved in this. We bought doses early on. From the day I got here, I was involved in buying doses of Moderna, Pfizer, and then J&J. And every dose that we didn't use, we are shipping and donating abroad. I mean, there has been an heroic effort by my colleagues, Dr. Hilary Marston, one of Dr. Fauci's, number 2s, has just done nothing else for the last 6 months. Not only Quillen from the White House, they have shipped out our doses that we bought, that we have been able to free up. We've shipped out 225 million to date to over 110 countries. And those are doses now. In addition, and if you look at the cost of those, that was about $4 billion of US taxpayer. I mean, that was the start. We then added to that, we did a deal first for 500 million, then for another 500 million for an additional 1 billion doses, right? From Pfizer. Now that's started, but that's over the next period of time, all to low, middle income countries. That costs I mean, all of us, taxpayers, another $7 billion. So we're up to about $11 billion in contributions. I think there's still a gap. We're working on that gap. I have been pretty vocal over the last couple of weeks that certainly one of the companies needs to stand up, and do more, and be able to help close the gap. We are working through COVAX. My guess is I'll let them speak, but there's a gap probably between 500 and a billion if you want to get to a 70% mark of low and low middle income countries. I think we are increasingly, what I'm hearing from my colleagues, that, and I don't want to say we've tackled the full supply problem, but increasingly there's an absorption problem. We are seeing doses that we have where getting uptake is becoming an issue. So I view that as good news, but we have to not only worry about supply, we have to worry about absorption and getting this in arms. With regard to whether our doses on boosters in kids are taking away from the rest of the world, let me just say, I mean, I think in the end of the day, the world's going to need boosters and kids protected. So I don't think, I think we're all going to have to recognize that. And we have an obligation to help make sure that they have enough to be able to do that, not just primary series.
So how should we assess the mental health implications caused by the pandemic in the coming decade, especially among our students? And is there a sense when we can begin to return to the usual social practices and dispense with the use of masks?
So there's a lot. Let me deal with the mental health part, and then we can talk about masks. My colleague, the Surgeon General, Vivek Murthy, I mean, is eloquent on this. It is clear that the pandemic has taken a very serious toll on the mental health of many, many, many people, especially young people who've had to sacrifice so much of their lives. There's been so much isolation. I think it is profound. I mean, we need to, this was true before, this is certainly true now. We need to invest in mental health services and treatments, which we have done. I think SAMHSA has issued some $2.5 billion in grants. There's been additional funds for pediatric mental health. And we need to understand that we are facing long-term effects of the pandemic. And we need to be able to offer support and treatment to people who need it. We've only begun to understand, and this is the tip of the iceberg. We have a major job ahead. With regard to your question of when we can remove masks at last, I understand this is a complicated question. I will tell you, before I go to bed every night, I look at the number of cases that the CDC, for that last 24-hour period. And, we have some 70,000 cases a day and still more than 1,000 deaths a day. And we need to do all we can to get the virus under control. I will tell you, I would be much happier answering that question if the caseload was below 30,000 or 20,000. I think the fact is the number of daily reported cases does translate, whether you're vaccinated or not, does have an effect. Dramatically different if you're vaccinated, right? I mean, what's the risk? 1 in 2,000 versus, 1 in 100 approximately, compared vaccinated. So it's just dramatically different. But we have to get cases down. I am uncomfortable with the 70,000 number. And I don't think it's a time for letting up on our preventive measures yet. I look forward to that day, getting kids vaccinated. This 5 to 11, I think, should help. I hope it helps. We'll see. There's still debate, but I hope it helps get the number of cases down.
So turning then to susceptibility factors, how should we, is there any data that indicates if there's a role that food and nutrition, food insecurity, risk factors like obesity and diabetes play in terms of vulnerability to COVID and severity of long-haul COVID complications? That's the first part of this question. There are more to follow, but we take that first.
Well, I should ask you that question, right? You should be the one who's answering that question. I can tell you we are all profoundly humbled, right, about the role of obesity, metabolic, metabolic abnormalities. And if you ever wanted a case for its effect on the immune system and susceptibility, I think we have it. And I don't think we fully understand. So Dr. Green, let me turn it around and let you answer that question.
Well, I wasn't expecting that you'd turn the tables on me that way, but it is indeed a highly complex issue, and both in terms of health and maintenance of good nutrition, as well as those individuals who are adversely affected by metabolic imbalances, either acquired or in many instances inherited. So it's just a highly complex web of factors, and I would hope that the powers that be will devote some energy and effort in unraveling those questions, and also, and here I'm sure your experience in the FDA and the strong measures that you took with respect to food labeling when you were commissioner of the FDA, that it is very important to ensure that fraudulent representations of protective measures are tightly controlled.
What do you think it is on obesity? I mean, if you look at just the clinical trial that was done, and the results we had on the Pfizer drug this morning was done in a high-risk population. And people go, well, that's only a high-risk population. And then you look, BMI of over 25 is listed on, may contribute, over 30, does contribute. That's 50, 60% of the population is at high risk. What is it, Dr. Green?
Well, I have two responses to that. First of all, I think that the obvious place to look is always the tip of the iceberg, and then uncover what lies beneath. And then with respect to the measures that can be reasonably taken, if we look at the epidemiology and the frighteningly high mortality that has occurred in certain countries, including the USA, we have a prevalence of risk factors like morbid obesity that are abundant, and that going to the future, hopefully we'll get a better control of COVID-19 at any rate. But if there's ever another epidemic, pandemic that comes down the pike, we are in a better position if we can control these risk factors. I don't know whether I've added any light or whether I've merely muddied the water some more.
It does give an urgency to it, doesn't it?
I'm sorry, you say?
I mean, it does give an urgency.
Yes.
I mean, to, the effects of nutrition, metabolic dysfunction, and obesity. I mean, it's just the effect has been profound here.
Right, and moving to the pediatric age group, we all know that that the foundations are laid with early nutrition, so that controlling that would be a giant step forward in avoiding the metabolic effects of food excess and obesity.
I agree.
I'm going to move on to the next question in the hope that you don't turn the tables on me again. Are there other comorbidities that have contributed to the impact of COVID? And how can we reflect on leveraging the toll it took on our nation to improve future outcomes? In a sense, I guess we've touched on that already, but if you'd like to add anything.
I think we've touched on it. I think that the other one, obviously, I mean, the primary one is age. And we saw the toll, and we are much more careful now. You look at boosts, making sure, I think we've done a good job of making sure that those who are most vulnerable in age have access. And you look at the vaccine uptake numbers, certainly the best numbers are in those who are elderly. I think that we do have to worry about equity across vulnerable populations, because I don't think age is necessarily the best predictor all the time, as my colleagues have pointed out. But I think age, obesity, and recognize particular vulnerabilities of vulnerable populations is key.
And earlier, I think you made the very good point that the segment of the population that is averse to receiving the vaccine may perhaps with time come to realize that morbidity and indeed mortality is diminished just by looking at the people in their own communities around them.
Yeah.
So
exactly.
The third portion of that question was, what is the estimated number of long-haul COVID-19 cases in the US, and if you have any numbers worldwide? Are there federal plans to address this?
Yeah, it has become, Dr. Collins has spoken about this. Let me assure you, it is, there's a lot of money being spent to research long effects of long-haul COVID. It's being studied. Look, it's quite clear. If you had any doubt, the virus attaching, pick an organ system. That's why the vaccines are so important. It's much better to intervene before those viruses attach to those receptors than having to deal with it after. There's a major effort and a major research program underway. I mean, there is, and there's no doubt that if you have a breakthrough case, as I understand it, and I leave it to my colleagues, the risk of long-haul COVID is less after vaccination, even in breakthrough cases, than compared to unvaccinated.
That certainly speaks eloquently to the need to receive vaccination. The next question is, will we need to receive annual COVID-19 booster vaccines? You've touched on that already, as we do for flu. And do you expect a new variant and a new surge this winter, if you want to get into the mode of prophesying the future?
Yeah, I think the one thing we have learned the hard way is not to do that. And I've tried to be responsive, Dr. Green, to your questions directly. But I've learned to duck that one, to be honest. I mean, the answer is we hope not, but we are. You look at surveillance. We were not doing surveillance in this country. We're now doing some 10,000 samples a week on the genomic surveillance. I think if we all do our part, we can contribute mightily to those surges. and variants. No variants have come close to competing with Delta. That's good news. Our vaccines continue to be highly protective, and the antiviral this morning, should work across just the fact that protease inhibitor. I mean, it should be independent of the variants. But I would be a fool if I didn't worry about the next variant.
Yeah, to invoke another famous seer sportsman, Yogi Berra stated that it's very difficult to predict, especially the future.
I will tell you the hardest thing for me, right, is exactly that. I mean, I had the privilege. I got called in last March, the then Vice President, Dr. Murthy, and I almost feel like I've been here before. As I said to you, I look at that curve every day, every night. We're sitting there 72,000, 70,000, 75,000 every night. We're clearly plateauing. The rate of decrease over the last 2 weeks has certainly dropped. And I am sitting here and I can't tell you, right, where we're going to be after Thanksgiving. Is this going to ascend? Is this going to stay in a plateau? Is this going to go down? And I can't even tell you where we're going to be. I will tell you, there was a moment, some of the modelers, and I remember saying this back last year, June, before he was president, and saying it to him directly, when the modelers came out that the peak would be in January, and at the end of that month, and the realization that imagine the feeling you may be at the peak of this when you assume the leadership of this country, because we saw that. I mean, and that rise. Once it's on the rise, the direction. Once it's going down, steady pace. But the place we're at right now, I don't know. It's humbling.
So many countries have followed very different approaches. What have we learned based on outcomes of those different approaches? And what did we get right in the US? What did we not get right? What do you believe the major lessons are learned that we've learned during the course of the pandemic?
Well, you just threw three questions. I guess go look at Israel's curve. Go look at the UK curve, right? And then try to explain it, right? Beginning of September, I think they were at 10,000 cases. Last I looked, Israel was under 1,000. Many more, obviously boosts, mitigation measures in place, a profound effect. I mean, UK, the curve was just the opposite at the same point in time. I think the thing we have to recognize is that this virus has thrown us curveballs and will continue to throw us curveballs. I spent this morning with Dr. Woodcock, Dr. Fauci, Dr. Walensky, Dr. Collins, after the meeting where we heard the data from Pfizer, and we spent talking through pandemic preparedness. I think there's a lot of work to be done by all of us to learn from these lessons, but we're not out of this yet. But I think, getting the unvaccinated vaccinated, getting everybody boosted who's eligible, getting kids done, getting an antiviral. I think, I'm more optimistic today than I've been in a long time.
Well, clearly the game is not over, although I will say that you certainly hit the ball out of the park on many of these questions, and we're very grateful for that. There's one more question on the preset ones, and then perhaps Dr. Haxu, Angela, if you're ready to pitch in there with some of the questions that have come from the audience, time permitting. So the last question is, and you, in a sense, I think, addressed it already, Dr. Kessler. How is the administration preparing for the next pandemic in general, both scientifically, socially, um, and then a sort of tail to that is in the present pandemic, where sequencing becomes cost prohibitive, are there other approaches that are being entertained in order to anticipate the next mutant form of COVID-19?
Yeah. I mean, you know, the whole world of diagnostics, I mean, I think has exploded. I won't turn that question back on you, Dr. Green, but let me just talk a little about where we should be thinking of going. There have been a number of articles written over the last number of years by our colleagues on pandemic preparedness, on prototypic pandemic preparedness. I think that no doubt the mRNA vaccines have demonstrated proof of concept, and clinical trial results have been beyond anything we would think. We know that's not going to be the only platform, but we need now to be preparing prototypes, both mRNA and other platforms for a whole host of viral families. We went from genomic identification to enough vaccine for all Americans in about 18 months. I think with planning, we should be able to do that and do some of the some of the prototypic preparedness before there's any pandemic, and do some of the phase 1 work such that if there were another strain or another virus family, we should be able to be ready to have those vaccines ready, not in just 18 months, but in 6 months or less. And I think there's also a lot of work that can be done in innovation, in process engineering. I think our biomedical engineers, you know, the field of vaccinology, we've been doing things in some ways as far as administration and distribution. I mean, look at the cold storage temperature issues. The mRNA technology, you know, I mean, has, I think, just been, we're all in awe. But, you know, shipping a vaccine at -80 is still not the most efficient way to do this. So there's a lot of room, you know, for our colleagues. You know, there's always, well, I don't know about you, but there's always an event, you know, that when we're growing up, I mean, as kids, I saw this after 9/11 when I was at Yale. You know, after 9/11, there were, you know, a lot of kids who, after that, wanted to go into the military. You know, I mean, these were, you know, graduates, you know, Yale graduates who wanted to go serve. I think for those of our young colleagues who have lived through this pandemic, there is a lot of work to be done. There are careers to be made here. And I think our job is to train them and offer them the opportunities, because we don't know when the next one's going to hit, but we're going to be dependent on them.
So, you know, with those concluding words, which I think sum up very well our current situation, I want to thank you again for taking the time to attend and enlighten all of us. And with that, I want to hand back to Dr. Brashear, who could then perhaps pass the baton to Angela if there's time for some additional questions.
Well, thank you so much, Dr. Green and Dr. Kessler. Dr. Huxley, we have time for one very short question.
Yes, so rapid fire. I try to synthesize several questions into this one from my colleagues Sacha Dandekar and Bill Murphy, and that's related to the government strategies to bring basic research advances to the bedside to treat and prevent COVID-19 in a very rapid manner in light of how the vaccine was, for example, developed.
I think when the history books are written, look, it's not because we are smarter today. It's because those who came before us made this investment in biomedical science some 50, 75 years ago. I mean, I sit every day at the interface of my colleagues at the Vaccine Research Center, as part of NIAID, the applied technology people as part of BARDA, the industry. And I will tell you, but for the Barney Grahams and John Mascolas, I mean, the basic science is what drove it. It wasn't because we were smart this time, it was because we made the investment back decades ago that positioned us. And I think no one should forget that.
So thank you, Dr. Kessler. Those are incredible words, and we all just are here because of the many contributions, including yourself. And we are just so appreciative that you shared with us your insight today and your incredible journey and your thoughts about the future. I want to thank Dr. Green, Dr. Haxu, and our audience for joining us today. We will be posting this online probably sometime next week. And I also want to say a great thank you to the entire team. These town halls have been absolutely wonderful. Thank you so much, Dr. Kessler.
Thank you for having me.